So hopefully I can keep your attention during the hyperglycemic phase until the hypoglycemia drifts in and you might not be with me so long. So my interest is hyperglycemia or glucose control in the newborn, and I'm going to talk to you today a bit about physiology and pathology. I'm not, I'm afraid, going to give you all the answers. I'm just going to try and raise a few questions and talk to you a bit about my thoughts and what we've been doing around this area of fairly controversial area. So to start off and get an idea of what your perspective is, the first question on Slido is, what is your definition of hyperglycemia within the neonatal unit? And I guess these are predominantly your kind of very preterm babies that are on the unit in intensive care. How would you define hyperglycemia? And all these definitions have been used in the literature and quoted in the literature in papers and publications, and is one of the challenges of trying to interpret the data in terms of every study chooses a different threshold. Does it come up on my screen or comes up down there? Comes up down there. Excellent. And I think that's fairly typical of what I would expect. So if that's your, so a fair range, I think a lot of people saying greater than 10, some greater than 12, but some even not really considering it a problem. But if that's your definition, I guess the other question is, we all have definitions of what it is, but when do you intervene? And maybe you've answered the same, maybe I should have said the question first, but when would you actually intervene in a baby? Because I think the two are slightly different. Interesting. So we're talking sort of most people, 50% greater than 12 plus glycosuria. So a fairly non-interventional group we have today, I think, compared to some of the UK practice, where in UK it tends to be greater than 10. But there is, again, quite a wide variation in practice. So that's in keeping. I think there's a survey. This was done from the New Zealand group who have a particular interest in glucose control in the newborn. And they did a survey, this is about 10 years ago. And what you can see here is the blood glucose level across the x-axis and the individual unit practices here. The circles that are predominantly focused around here are what they would define hyperglycemia as. The squares are where they would intervene to treat, which is shifted similarly to the audience here's response, slightly to the right, so they wouldn't intervene till slightly higher. But I think what's interesting is once they've decided to intervene, their actual target that they would aim to keep this baby at are actually lower than where they would have intervened, suggesting that actually you think the optimal target is somewhere down here, even though you're not intervening until it's much higher. So how much of a problem is hyperglycemia on the unit? Well, I think if you don't think it's a problem, you don't look for it, and if you don't look for it, you won't see it. And what we did was look back using some blinded data that we'd collected using continuous glucose monitoring. So for any of you that look after children with diabetes, you're probably familiar with the kind of increase in use of continuous glucose monitors to get a 24-hour day, 7 days view of what's happening with children's glucose control when they're diabetic. And they haven't been particularly used in neonates, but that's one of the areas that we're quite interested in. So these sensors and continuous monitors were used as part of a large trial, 8 centres across UK and Europe. And what we did is we looked at the control arm of the study and what the prevalence of hyperglycemia were in the control arm. And this was done over the first week of life. And in the first week of life, these babies that were recruited were less than 1,500 grams in level 3 neonatal units. And you can see that the prevalence of hyperglycemia with a definition of greater than 8 was about 80%, greater than 10, about 60%. And then there were some babies that really had quite significant, what I would consider quite significant hypoglycemia, greater than 15 and greater than 20. A lot of this onset was actually less than 48 hours of age. One of the groups that we worked with that worked in Barcelona then went on to look at these very low birth babies as they were about to go home from the unit, again using these blinded CGM monitors. So these were babies that are just about to go out the door. Well, everybody was happy, they were stable. They put the sensors on for 48 hours, and then this is the individual babies and the percentage of time in different thresholds. The thresholds here they used were less than 2.6 for hypo and greater than 8 for hyperglycemia, because these were felt to be more stable babies. And what's interesting you can see is that some of these babies were having quite significant periods of time greater than 8. In that period that we thought that they were quite stable. But what does it mean? Is that entirely physiological? Is it normal for babies to have fluctuating glucose levels, or is it pathology? So I kind of think of our preterm babies as a mixture of preterm physiology plus the kind of intensive care, critical care pathology. And if you think of our preterm babies, they actually don't produce insulin in the same way that your term baby does. There's less conversion of proinsulin to insulin, so you have high proinsulin levels that are not so active as insulin. They often are a bit growth restricted, they'll have less muscle mass, less glucose receptors in the muscle to take up glucose, making them to some extent relatively insulin deficient. But they've also got a whole host of pathologies related to critical illness. They may be septic with increasing catecholamines, cytokines that will make them insulin resistant, or we may give them inotropes, and inotropes are very good at suppressing your insulin secretion. So there's a combination of physiology and pathology going on in these babies. There's a wealth of literature though, showing an association between hyperglycemia and mortality. But as you've heard from a number of the lectures already this week, the fact you've got an association doesn't mean causality, but it raises concerns. However, the cynicists in the audience will say, well, it's all just to do with the sicker babies. They're the ones that get high sugars. And this is a paper from, again, the New Zealand group looking at the relationship between measurements of neonatal glycemia and 2-year outcome in cohort of preterm babies. And I'm not sure it projects that well, I'm sorry about that, but what it essentially shows, and you can go and have a look at the paper, is that if you look at hyperglycemia, here this is hypo, hyper and unstable glucose levels, in a univariate analysis, then survival without morbidity or survival without neurodevelopmental impairment at 2 years are both related to your glycemic control and hyperglycemia. So worse outcome if you're hyperglycemic. But if you put in gestational age and birth weight SDS, that relationship disappears. But as a neonatologist, I'm faced with a preterm baby that I have to manage, and I can't change its gestational age, but I would like to find some modifiable risk factors. And I think most risk factors for babies being ill are related to their gestational age. So you could essentially throw the baby out with the bathwater if you throw all of these potential risks out and just dismiss them all. But I guess to know whether you can dismiss them, you have to think of something in terms of whether it's biologically plausible. Is it biologically plausible that hyperglycemia could cause you problems? And there's a number of animal studies and studies in adult ITU looking at the impact of hyperglycemia on oxidative stress, immune dysfunction, coagulopathy. It's pro-inflammatory. So lots of reasons why hyperglycemia might cause morbidity and mortality. And one of the things I think we face in the neonatal unit is the challenge of managing babies' fluid balance. And if babies become hyperglycemic, particularly those very preterm babies, less than 26 weeks, often they can have problems of fluid balance, they become hypernatremic, you end up putting more fluids in, and they become more hyperglycemic. And this has been associated with both intraventricular hemorrhage and ducts. And this is one of the papers that was published, I think, about 2 years ago now, looking at that relationship between hyperglycemia in the first 96 hours and its association with severe intraventricular hemorrhage. But I equally would be a little bit suspicious, because we have to bear in mind that in adults, if you have a brain injury, or children with brain injury, that causes a significant reaction, and you will find hyperglycemia as a reactive response. So we do have to be cautious, but this is a sort of clear association between relative duration of hyperglycemia and intraventricular hemorrhage. But as a neonatologist, I'm probably more worried about white matter damage and more chronic, smaller lesions than just large IVH. And this paper came out from the Stockholm group a few years ago, where they looked at extremely preterm babies. They had about 100 extremely preterm, under a kilo babies. They did MRIs at term, and they looked at the relationship between hyperglycemia, which they defined as greater than 8.3, and both reduction in white matter at term and a risk of death. And they showed quite significant relative risk if you had hyperglycemia greater than 8.3 in the first 24 hours of life, and these outcomes. But as David told us yesterday, we shouldn't be looking at MRIs, we should be looking at the connectome. And if you have any questions about this slide, please refer them to David. My simple understanding of this is that it's a study that essentially isn't done in preterm babies, but hopefully we can learn something from it. It's done in adults with type 2 diabetes. And the reason for that is because there's not a lot of research in preterms with hyperglycemia, but there's a lot of interest in type 2 diabetes and diabetes in the adult population, and what impact it has on cognition. So what this group did is they took middle-aged men with type 2 diabetes, and they did MRIs using DTI and looked at the neural networks in these adults compared to age-matched and education-matched controls. And what they said they showed was that there was a worse network integration. So these adults were not so good at integrating information, and they felt that this showed that the hyperglycemia was associated with cognitive decline in these adults. And I think that's interesting to me as a neonatologist, where a lot of the complex integration of information is really important for our preterm babies, and that's where we're seeing some of the problems in our children when they're older. I'm a bit of a more traditionalist, and rather than looking at neural networks, which I defer to other people for, if you look at more classic histology, and this is the classic histology of pyramidal cells and their connections. This is called Golgi staining. It's a bit of alchemy. Nobody quite understands how it works, but it stains beautifully the morphology of pyramidal cells, which have a single long axon, but lots of dendritic connections. And this dendritic arbor has also got multiple spines on it, which means these cells have fantastic connectivity. And what this group were interested in, again, in the sort of setting of diabetes, is it important to have to prevent hyperglycemia or hypoglycemia? So they had a mouse model whereby they exposed mice from about 4 weeks of age to a model of hypoglycemia, where they gave them 3 days a week of insulin to make them hypoglycemic, or they exposed them to hyperglycemia using the classic diabetic model, which is to treat them with streptozocin, which destroys your pancreatic cells, so you become hyperglycemic. And the hyperglycemic levels were similar to those we would see in our preterm population, sort of above 10 millimoles per litre or 200 mg per deciliter. And then when they euthanized these animals, you can see a picture of a control animal here with quite a complex dendritic arbor showing lots of connectivities. This is the dendritic arbor of a mouse that was exposed to intermittent hypoglycemia, and we all worry about hypoglycemia in our preterm population and are concerned if they have prolonged hypoglycemia. This is the dendritic arbor of the mice exposed to hypoglycemia, quite dramatic changes. It's a mouse model, but it makes you think and question. What's also interesting is morphology is one thing, but what about behaviour? So before they euthanized these animals, they made them undertake some behavioural testing in the radial arm water maze, and we heard a little bit about that yesterday. Essentially what you do is you train these animals to go to a reward, and you see how many errors they make. So they train them with gave them 12 tests to see whether they could get trained into doing it, and as you'd imagine, they got better during these 12 training sessions. And essentially, whether you were hypoglycemic or control, you were equally good at doing this test. They then gave them a bit of a rest for an hour, and they went back to do the same test again. But then, at this point, an hour later, the control and the hypoglycemic animals here seemed to be able to remember, whereas those that had been exposed to hyperglycemia couldn't remember. And the same thing was found at 24 hours, suggesting that hyperglycemia is actually having functional outcome problems as well as just changes that we can see morphologically. What about other morbidities? So other morbidities that are potentially associated or maybe causal. This was a very interesting paper that came out in Science last year. Again, it was a group that weren't interested in neonatal hyperglycemia. They were interested in the relationship between obesity and gut dysfunction. And they were looking for the underlying mechanism for this. And they did a number of studies, quite detailed studies, cell animals in adult models, and they came to the conclusion that actually it was the hyperglycemia that was driving intestinal barrier dysfunction. So what they did, again, they used the typical mouse model of using streptozocin to cause diabetes. They had this diabetic mouse, and then they exposed it to a model of E. coli sepsis. And the bacterium was biofluorescent, so you could track that bacteria through the gut wall in these mice. And what you can see here is time in hours across the x-axis and the luminescence count. So that's the number of bacteria that have crossed the gut wall. And here in the control arm, you've got some bacteria going through, but in those that were treated with streptozocin, you've got much greater gut translocation of the bacteria from the lumen in through the gut wall. And it wasn't related to the load of bacteria in the gut itself. That didn't change. So if you want to prove that it's the high glucose levels, you've got to then reverse them. So in good scientific fashion, they then treated the animals with insulin or control, placebo, and again you can see time on the x-axis and the luminescence count on the y-axis. And here you have the patients that were, the animals that were then treated with insulin, their counts came down. And I was quite surprised by these results, but it made me question in the context of our preterm babies where intestinal barrier function and epithelial function is really critical for things like necrotizing enterocolitis. Makes us wonder whether, rather than hyperglycemia being purely a function of things like sepsis, whether it actually is part and parcel of the pathology of that process of why we become septic. So hopefully that's kind of giving you a flavour of why I think hyperglycemia might be important. What about how we should treat? And this is equally, I think, quite controversial. So on your unit, another Slido, if you're still awake and with us, what would you do in a baby that was a 24-weeker, 680 grams, 24 hours of age, and the blood glucose is risen to 10 millimoles per litre? What are you going to do? There's a lot of dogma around this, I think. There seem to be camps. So lots of people reducing dextrose infusion. Lots of people sitting tight say, let's wait and see. I'm glad that nobody stopped their parenteral nutrition. Excellent. So this was put in with the concern that people have about parenteral nutrition. So this is a paper from Oslo that came out, I think, 5 years ago now, I think, which was a concern in that it highlighted that they had had a change in practice on their unit, and they'd introduced early and enhanced parenteral nutrition. And in doing so and changing their nutritional policy, they had found that they had a significant increase in hyperglycemia and an increase in deaths. And this sort of raised concerns, I think, as to whether this kind of advent of trying to increase your nutritional intake was really beneficial. But I think what's important is that it wasn't the early enhanced parenteral nutrition that was found to be associated with increased mortality. It was the hyperglycemia during the first week. And here you can see severe hyperglycemia had a significant relationship with death. Interestingly, the group then changed their practice, and they published again 2 years ago, looking at a intervention where they had tighter control of their glucose infusion rates, and they looked at the relationship between glucose infusion rates and other things on the unit and how that affected their hyperglycemia. And what I think is interesting is, yes, there's a relationship between your glucose infusion rate and your risk of hyperglycemia, but there's also other things. There's lipids, your gestational age, whether you're ventilated or whether you're on inotropes, all putting into the mix. It's not purely glucose infusion. And if you actually look at the raw data from this study, the actual mean glucose infusion rate in all the babies in the two different cohorts actually was exactly the same. There wasn't an overall mean increase or mean decrease, so it must have been specific babies that were having at specific times particularly high glucose infusion rates. And the reason that I put that because I want to, in a way, dismiss it that it's not just starting parenteral nutrition, because I think historically people feel that parenteral nutrition was the cause of all the problems. And there's some nice work done by Colin Morgan from Liverpool, who's been looking at amino acids and specific amino acids, and the one he's interested in is arginine, because there's a lot of animal data showing that actually insulin secretion, particularly in the neonatal period, is regulated by certain amino acids, and particularly arginine. And in their unit, they tried to increase their amino acid intake in their parenteral nutrition. And what you can see here is age across the x-axis and the percentage of infants on insulin, which are these bars, and their mean glucose in two cohorts, one prior to starting their early enhanced parenteral nutrition and after having started it. And the mean glucoses are about the same, but their use of insulin actually came down significantly when they introduced their SCAMP regime, suggesting that they had less problems of glucose control. And I think it's the use of insulin in neonates that is what people worry about. So the role of insulin. So it's a great drug, she says. It attenuates catabolism, increases protein synthesis in young animals. It's good at preventing proteolysis. suppression of pro-inflammatories, lots of good things that it might do that might be beneficial. But I think the thing as neonatologists we all worry about is hypoglycemia. Even though, as I say, hypoglycemia might not be as bad as hyperglycemia. But we had our fingers burnt. We did a large trial using early insulin in the preterm population some years ago now. This was predominantly aimed at promoting anabolism. It wasn't to treat hypoglycemia. So this study recruited all very low birth weight babies on the unit, randomized them to having either early insulin, 0.05 units per kilo per hour, within the first 24 hours for the first week, or control. We used the blinded CGM in these babies to look at glucose control, and we saw a significant increase in the prevalence of hypoglycemia. But what I think is also interesting, if you look just at the control arm of this study, here it was reported with blood glucose monitoring that about 2% of these babies had hypoglycemia less than 2.6 for an hour. But if you looked in the data we'd collected using the sensor, which was collecting continuous data, there's a 17% of those babies had those periods of hypoglycemia that the clinicians were unaware of. And those periods actually in the control arm were really quite long. They were 5 and 6 hours, where these babies hadn't had a blood sugar taken and they were less than 2.6. So I think we're not entirely sure what's happening with glucose control in some of these babies. So the only trial of insulin in terms of a randomized control trial of using insulin to treat hypoglycemia is this paper, which is from the New Zealand group from Jane Elsvier. It's a small single centre study looking at 88 babies, less than 1,500 grams. Their target was 4 to 6. I think that's very tight. To try and target in these babies 4 to 6, I think was quite challenging. And I think they found that. They weren't doing continuous monitoring. They were just monitoring these babies with regular blood glucoses. They showed a statistically significant reduction in their mean blood glucose, 5.7 versus 6.5. But the hypoglycemia rate was really, I think, quite high in the intervention, although I would say it's quite high in their control as well. What's interesting, though, is if you look at the values within the target and the target and a similar target, actually a lot of the ones in the control had a significant amount of time within this target. I should have been more specific. So the target for the tight is 4 to 6, but 36% of the time the controls were in that target as well. So trying to look at outcomes and differences if you haven't got a clear watershed. They then went on to look at long-term outcome, and this is being published. And the long-term outcomes, they suggest, shows that there's no significant difference in long-term outcome in those randomized to the intervention to tight glycemic control. But I think it's important, and bearing up the discussions this morning about looking at trials and the power of trials and making too many assumptions on a lack of data, and absence of evidence isn't evidence of absence. This was a cohort of 80 babies that were seen at 2 years of age, and they showed that survival without neurodevelopmental impairment, you've got 40% in the tight arm, 33% in the standard. So that's a 7% difference. A 7% difference wouldn't be bad. If I showed a 10% improvement in my outcome, I'd be quite happy in most trials. Most trials would be very happy. But this study wasn't powered for that. In fact, this power had 80% power to detect a 36% difference. So this trial was never going to show significance unless, statistical significance, unless they'd shown a 36% difference in their primary outcome. So I think we have to be cautious in how we dismiss interventions unless we've done appropriately powered studies. Trials can be good, observational data can be good, but observational data also has limitations, as we heard earlier. This is data from the Express study from Sweden, and what this group did was they looked at all the Express data of babies across Sweden, and they looked at the relationship between hypoglycemia and insulin treatment and mortality. And what you can see here is different definitions of hypoglycemia, so thresholds greater than 10 or greater than 12, and mortality if you were treated with insulin, or mortality if you were untreated. And you've got mortality at 28 days or at 70 days. And if you were untreated, your mortality here at 28 days is about 13%, whereas those that were treated, it's much lower. And again, that holds at 70 days. It has all the challenges of observational data, of that pulling all the data together, different units. They try to look at different practices in different units because inevitably different units have different thresholds for when they'll intervene. But it's quite a difference, and I think, again, it's a pause to thought. So, hyperglycemia, lots of controversies. I think controlling blood glucose is important, but it's challenging. Most of us would desire to control it, but without compromising nutrition. Insulin sensitivity is notoriously variable. We all know you give insulin to one baby and its blood sugar will not move at all. You give it to the next baby the same dose and it will fall really rapidly. So it's a significant risk. So what do we do? Well, my concern is that traditional measurements have significant limitations. We want to do minimal handling in these babies, we don't want to take too much blood, so we don't measure blood sugar very frequently. So you can't intervene if you're not measuring something. We don't practice medicine here where we do a saturation on a baby in the morning and then we go away and say, well, let's come back and do a saturation tomorrow morning and decide how much oxygen we're going to give that baby. We would feel that that was not really appropriate. And yet we treat glucose in slightly that way. We take a blood sugar, and certainly on our unit, 5-6 years ago, maybe 10 years ago now, babies wouldn't have a blood sugar for 12 hours or plus, and particularly when they were more mature. So that's why we were being very interested in using these continuous monitors, even in our very small babies. They sit in the subcutaneous tissue, so they're not measuring blood glucose. They're measuring trends, a bit like a SATS monitor or your TCO2 monitors. They're good at measuring trends. They are not, and I won't claim they are as accurate as a blood glucose, but we found they work very well and are being quite accurate. And we were funded to use these, to look at these devices to see whether they could be used in our preterm population, to do a trial, and also to do a study using closed loop, which I will talk a little bit about. So what did our trial involve? All the babies under 1,200 grams. We chose 1,200 grams because those were the babies we thought were the most significantly at risk of abnormal glucose control. Were approached, our parents were asked and consented whether they would be interested in being involved. All the babies had sensors inserted within 24 hours of life. If you ever run a trial, 24 hours of life within delivery is not the way to go if you want a good night's sleep, but that's what we did. Sensors are inserted. If you were randomized to the control arm, they had a monitor at the cot side, but it was blinded. They have to be calibrated every 12 hours, but the clinical team couldn't see what was happening and what the sensor glucose was showing. Those in the intervention arm, on the other hand, had the monitor at the cot side. The nurses could see it. They could see it in real time all the time. But what we did was we encouraged them to look at it and record it in keeping with all of the sort of standard care, so every hour. And they had an algorithm to try and encourage them to target glucose control, because giving someone information without telling them what to do with it is a little unfair. And the aim was to try and target glucose control. I would like to show you the results, but the study has just finished and all the data is being closed, so I can't show the results, but they hopefully will be coming out in the autumn. But what I will just show you some data about is another study, the study about closed loop that we did alongside this. And that was based on the fact that you're probably aware that there's a lot of interest in closed loop in diabetic treatment. And this device gives us lots of information. It's there constantly, but you cannot expect on a busy neonatal unit the nursing staff to respond to it constantly. And so what we want to know is whether we could actually use that data in a better way. Not only are the staff busy, but every baby, as I've said, is individual in its response to insulin, individual in its insulin sensitivity on the infusions it's getting, how much dextrose, how much nutrition. So trying to design a paper algorithm that copes with all those different variables is really hard. And also nursing staff are risk averse and would often rather not do than do. So getting people to be proactive is quite hard. Whereas the monitor and a computer can be completely unemotional. We're very lucky in Cambridge that we have this gentleman, Roman Havorka, who is the sort of world expert on algorithms. And he used some of the data we'd collected previously in our preterm population to design an algorithm, developed it in silico to make sure that it kind of responded appropriately and was safe. And what we designed it to was to respond every 15 minutes to give advice on insulin infusion. We designed it to be as simple as possible because we knew that neonatal units were complex, as I've said, with all these different infusions, and we didn't want nurses to have to put in lots of information on how much feed is this baby on, how many inotropes are they on, what's the dose of this, and that changing so frequently in a 24-hour period. So it simply said, if your blood glucose is this, you need to give some insulin or you need to drop the dextrose. And that's also because every neonatologist will have a plan as to what's happening with nutrition and should have optimised nutrition for that baby in the morning as part of the ward round. And we didn't want to interfere with that. And what's unique about this is that it also adapts to the baby. So if you've given it a blood glucose and it's told you what to do, and the result has been that 15 minutes later the sense glucose has changed, when you come to ask it what to do next, it will have learnt from the response to what happened the last time it gave you an instruction, so that 24 hours later it will give you a more personalised approach. And this is just a graph of a small study. It's only 10 babies in each arm. On this side you've got continuous glucose monitoring essentially being done by the nursing staff for the first week of life. And on this side, you have continuous glucose monitoring started with just the paper algorithm, and then over this time period here, the algorithm was used to try and target glucose control. And what you can see is over this 24-hour period, the computer algorithm was decidedly better than we were as clinical team in targeting glucose control, and it was targeting it between 4 and 8. So it did quite well. And what was interesting is all the babies in the closed loop were given insulin, but the overall dose for the week didn't actually change. So it seems to be giving it in a slightly different way and improving our ability to target. So I think the way to move is somewhat more personalised, and I say that not personalised just because we can use technology to do that, but I think when we're thinking of hyperglycemia, all these babies are potentially at risk of hyperglycemia, but they're all very different. And I think what you should be targeting in these two babies, we would say, is probably very different. But equally, you cannot use the same guideline for a baby that's being cooled as a baby that's 23, 24 weeks. And increasingly, you've also got to bear in mind that this 23-weeker is actually quite different from this 24, 25-weeker. So they're very different. And we should actually think about the physiology in the baby before we suddenly set a threshold and say that's what we should do. And also in the same mindset of personalised medicine, as neonatologists, we get very caught up in the acute aspect of what we're doing, of saving babies' lives and getting them out of the neonatal unit. But there is a concern about what's happening to the future of these babies. And we've talked about neurodevelopment and the impact potentially on these babies' neurodevelopment. But there's a lot of work in small for gestational age babies and their potential long-term risk of metabolic syndrome. There's a lot of controversy as to whether our very low birth weight, our preterm babies are, but we certainly at the moment are growth restricting our babies in the post-neonatal period. This is now quite old data. It was in the New England Journal many years ago now, but what it showed was young adults who had been born very low birth weight and gave them an oral glucose tolerance test in their early 20s. What you can see here is the fasting glucose levels between the very low birth weight and the term adolescents, and there's not a significant difference in their fasting glucose. If you look at their 2-hour glucose level, it begins to look a little bit different, but if you then look at their response in terms of their insulin secretion, they have much more significant increase in insulin secretion, and their insulin resistance measured by HOMA is really quite significantly different in adolescents. So I think what we do and how we manage them from a nutritional point of view and also giving insulin, we have to be cautious about. We had hoped to follow up all of our nurture cohort and hope to carry on following up some of our more recent babies in interventions. One small group that were followed up was a group from Amsterdam, and we wanted to be sure that we weren't causing problems. It's only a small cohort, it's only 40 patients, again, limitations of power with what we can show. I think all I was reassured was that they looked at the kind of adult markers of metabolic disease, and there wasn't a significant difference between the standard care and the early insulin, apart from triglycerides. It was one marker, but at least reassuringly, it was worse in the standard care than the early insulin arm. So it's something, again, that I think needs follow-up. So what would I say in terms of clinical practice? I think glucose is a really important biomarker. It's cheap, it's easy, we do it on the neonatal unit. Rather than thinking of thresholds, I've not ever mentioned what I think is the threshold for hyperglycemia or hypoglycemia. I think you should think of it as a biomarker. What is it telling you about your baby? So if you've got a septic baby, if you've got a hypoglycemic baby, is it septic? Are you not giving enough nutrition? Are you giving too much nutrition? Are they catabolic? Are you giving loads of inotropes? Are you drawing off their inotropes and then making them hypoglycemic? And that is certainly something we see quite a bit on our unit, that we're trying to target glucose control. You have a baby on insulin, you then reduce their inotropes, and that's actually quite a significant risk period. And we found that with the CGM. People were unaware, they were weaning inotropes, their insulin sensitivity increased, and then they dropped their blood sugars. Inflammation, enterprise. Think about why that baby is hyperglycemic or hypoglycemic. My advice, first think who and why. Who are you treating and why? And that's about you and the physiology. Assess their glucose load. It's not all about glucose load, but certainly if you're giving excess, so if you're giving more than 10 mg per kilo per minute, why are you giving more than 10 mg per kilo per minute? So think about that and try and reduce that. We would probably not go terribly low. I think on our unit we will keep your dextrose intake about 6 mg per kilo per minute. I wouldn't want to go much lower than that in a preterm baby that there's not other things going on. When you're targeting blood glucose, I think you have to balance your risks. So if you're monitoring them frequently, you're able to monitor them, or you do monitor them, then you can be more targeted. If you know that you're not going to be able to monitor that baby, then maybe you have to have wider targets. And you know what the practice is on your unit and have to decide where you want to put your risks. Early amino acid administration is important. It reduces catabolism, so I would encourage that. And I'm glad to see that nobody's suddenly stopping parenteral nutrition because of hyperglycemia. And insulin treatment, I think, can be used, but you must do monitoring. And I think to dismiss it because of concerns about low blood sugars means that you're just not monitoring your baby's effect frequently enough. What next? So I think we've moved a long way in terms of glucose monitoring, but I think we've got a long way to go. We are increasingly using the continuous glucose monitorings on our unit, and I'd be interested to know whether anyone else is. I know that there's a group in Poland and Hungary have started using them on some of their babies. I would be to some extent cautious as part of the trial. We found some people love the monitors, but they are not designed for neonates. They're not licensed for neonates. I think if we're using them, then you need to be trained, you need to know what you're doing. The sensors are, it's not ideal to put the sensors in using the introducers. The introducers insert the sensors at 90 degrees. You have to insert them by hand parallel to the skin. So I'm not advocating everybody going out there and using these. I think it's a way that things hopefully will move, but hopefully we've got to take the industry with us, and we've got the industry to actually make a monitor that is designed for neonates, not one that we've got cast off from our adult population. And I'm trying to work on that, hopefully. Equally, with whether you're looking at low sugars or high sugars, it's not just sugars. I think I've put this here. This is just a metabolomic chart of lipid metabolism in different babies and different feeds. And it's important to know what's actually happening with other metabolites. If you're deciding to intervene on glucose, try and think about the picture for that baby. And that will help you to make a much better decision in terms of what the best management is. And also trying to close the loop is about looking at what the implications are for the future of these children and what we've done. And that, I think, is more about looking not at MRIs, and I would again agree, looking at large lesions on MRI is not what we should be doing. We want our children to be functioning, multitasking individuals, and we need to be looking at the right outcomes. Bailey's is not the right outcome if we want to look at their functioning, but getting funding to look at that is quite challenging. And equally, I think, as well as looking at neurodevelopmental outcomes, if we're talking about metabolic changes and metabolic interventions in this neonatal period, we need to look at these children in terms of their long-term metabolism, and that's really important. So with that, I will end and say thank you to all the people that have supported me in some of the studies that we've been doing. Thank you.